G'day, I'd like to let you know that Aussie Med Ed is sponsored by Tego. For most doctors, indemnity insurance is one of their biggest costs of practice. While many doctors are still with the same insurer they joined in medical school, many have made the switch to Tego and benefited from it. The team at Tego have told me that those new to private practice could qualify for 4 years of discounted premiums. To find out more about Tego, visit tego.com.au. That's tego.com.au. G'day and welcome to the Aussie Med Ed, the Australian medical education podcast, where we get to interview specialists in a variety of medical areas, asking their opinion on their certain conditions and obtaining their insight into how they diagnose and treat that condition. In these COVID times, it's a way of replacing the relaxed discussion around the hospital by allowing the listener to put forward questions to be answered and addressed on their behalf. I hope you enjoy the whole program and welcome once again to Aussie Med Ed. And today we're joined by Dr Vamsee Thalluri, a reproductive medicine and infertility specialist at Reproductive Medicine. He completed medical school in Adelaide and subsequently undertook specialist training in the field of obstetrics and gynecology. Following this, he subspecialised in the field of reproductive endocrinology and infertility with a further 3 years of training and exams. Today he's going to talk to us about infertility issues and treatment options that are available. I'm Gavin Nimon, an orthopaedic surgeon based in Adelaide and also a senior lecturer at the University of Adelaide involved in orthopaedic musculoskeletal teaching. I hope you enjoy the podcast series, and if so, please feel free to subscribe, give us a like or review, or tell your friends about it. We look forward to having you listen to our podcast series, and we hope you find it enjoyable. Not only will this information be useful for the general practitioner seeing a patient on a regular basis, but also for the medical student revising for their exams or preparing for their OSCE examination. I'd like to begin this podcast by acknowledging the traditional custodians of the land on which this podcast has been produced, and pay my respects to the elders both past and present. Well, it now gives me great pleasure to introduce Dr Vamsee Thalluri. He's a reproductive medicine and infertility specialist at Reproductive Medicine in Adelaide. Welcome, Vamsee.
Thank you for having me.
It's great to have you on board on Aussie Med Ed. What actually took you into this field?
I still remember my obstetrics rotation or ONG rotation in fifth year, I think it was. That was probably one of my favourite rotations. And I was like, look, I really enjoyed that. And so that's what I did. And obviously really enjoyed doing obstetrics and certainly obviously delivering babies. But then obviously came across the field of fertility. And I think the thing that really sort of appealed to it for me was it was a beautiful sort of mix between science and procedural work. You're generally dealing with young, healthy people with very good sort of prognosis. From day one, absolutely loved it and have been doing it ever since. And super, super rewarding job. I mean, as you can probably imagine, helping people or helping couples trying to fall pregnant and they're not, and seeing them when they come back in to show you their baby that they're so proud of. Look, it's the best part of my job and it doesn't really get any better than that. So that probably explains it in it itself, really.
It must be quite a double-edged sword, having the joy of delivering babies as an obstetrician, but then realising a large percent of people have difficulty conceiving a child. And I believe infertility is quite a common issue. I've read figures of 1 in 6 couples may have problems. Is that correct?
Look, you're exactly right. Like, the figures you'd sort of see out there are, 1 in 6, 1 in 7 couples need some help in terms of achieving pregnancy. And in terms of the IVF statistics, it's about 1 in 23, 1 in 24 children in Australia are born with the help of IVF. It's obviously a super sort of private area, and so you don't have people sort of necessarily putting it up on their Facebook and that sort of thing. But when you tell sort of couples these sorts of statistics that, on average, 1 child in every classroom is born with IVF, people are genuinely quite surprised. And again, I think it just comes back to that thing that it's a private thing. People don't sort of advertise necessarily. That's what they've had to go through. But look, as you alluded to, very, very common problem.
And what sort of definition would you put down for infertility? Is it a certain period of time of trying to conceive that determines whether someone becomes under the umbrella of an infertile couple, or how do you define them?
It's probably not a specific definition in terms of time. There are sort of some timelines that we would use to help guide people when they should go and perhaps seek help or get some tests done. But look, the textbook definition of infertility would be failure to achieve pregnancy after regular unprotected intercourse. That's the textbook definition. But again, in terms of when someone should require help, the broad sort of guidance we give is based off a woman's age. And that's like one of the most common sort of causes of infertility, I guess. And so we would generally say if a woman is under the age of 35, a couple should try for about 12 months on their own before perhaps seeking help. Now, it doesn't mean you have to wait 12 months, of course, but that's just sort of a general guidance. And if a woman is above the age of 35, then try for about 6 months on your own before perhaps getting some tests done. Now, this is in the absence of any known problems. So if someone obviously is not getting a menstrual cycle at all, or is getting a very irregular menstrual cycle, or a guy knows that he's had a testicle removed before, I wouldn't then say wait for 12 months on your own. You can go and get tests and those sorts of things done earlier than that, but as a general rule, that's a pretty good guide.
And if we try and divide infertility into types of causes, I like to think of things in groups of threes. It's just my way of actually conceptualising different options. And so when I thought about before this interview, I was thinking of male, female, and a combined aspect. How would you sort of tend to define infertility into different groups or subgroups of causes?
Yeah, I think you've hit the nail on the head. There's obviously you've got your female causes, you've got your male causes, and about 30-40% of the time, there's both partners have an issue going on. And if you go into sort of focus on the female causes, I mean, as you can probably imagine, you could have a list as long as your arm that sort of goes into the very specific sort of disorders or things that can cause infertility. But broadly speaking, I would split it up into sort of the following. So I would say, one, a woman's age. And when we're talking about a woman's age, what we're really referring to is egg quality. Fortunately, there's no real test for egg quality. You can do a test for egg number, though that's not in itself a cause of infertility necessarily, but egg quality certainly is. I would then sort of move on to things like ovulatory disorders. So if a woman, for whatever reason, and polycystic ovarian syndrome is perhaps the most common reason, if a woman has a very irregular or an absent cycle, obviously if a woman is not releasing an egg, then it's very difficult to fall pregnant, or if the woman doesn't know when she's ovulating, makes intercourse timing very difficult, and again, that makes pregnancy difficult to achieve. So again, ovulatory related disorders are a common cause as well. And then you could kind of move on to more anatomical factors. So one of the more common ones, say tubal factors. So if someone has had their tubes blocked, for instance, whether it's a previous pelvic infection or an STI like chlamydia, gonorrhea, for instance, which is obviously particularly common, those things can cause tubal-related problems, which if there's a problem with the tube, it means that sperm can't actually meet the egg in the tube, and therefore creating an embryo is not going to be possible, which again won't lead to pregnancy. Other sort of anatomical problems, you could find problems with a woman's uterus, for instance. So you could have fibroids, you can have polyps, you can have intrauterine adhesions. These things can affect the ability for an embryo to actually implant in the uterus. You can have all sort of embryological or developmental sort of problems within the uterus as well, what we would call Müllerian duct anomalies. Some of them can cause infertility as well. And then you have sort of other sort of implantation-related problems. So there are some very sort of rarer conditions that you might look for, thrombophilias, etc. One of the more common problems that's associated with infertility is endometriosis, which not that many people realize is an implantation problem. Endometriosis is very, very common, where the problem is when a woman's lining, known as the endometrium, implants outside the uterus. And these are very subtle deposits, and often they cause pain. And so I think the awareness of pelvic pain and its association with endometriosis is becoming well known. But endometriosis is a very unusual condition in that it doesn't always present with pain, and it certainly can cause infertility because these endometriosis deposits can release various cytokines and natural killer cells and various other inflammatory markers that can make it harder for an embryo to implant. So very, very common problem, that one. Other sort of broad sort of topics would be genetics. So if someone has a translocation, for instance, it might mean that their eggs are abnormal, or other conditions such as Turner syndrome, where perhaps they run out of eggs or go into premature ovarian insufficiency very early in life. So there are other possible problems. And then I would sort of put another basket as sort of environmental factors. So things like obesity or smoking or iatrogenic causes such as having to have an ovary removed due to a big cyst, etc. So they could also be causes. So that's how I would probably group the female causes. As I said, there are all sorts of other more specific causes as well, but if I had to sort of group them into various sort of topics, that's how I would do it.
Well, that's an absolutely beautiful concept. I just love the way you've listed off in a very structured way female causes of infertility and a beautiful medical student summary. So I could imagine students studying for their exams, writing this down is a great way of actually conceptualizing all this. So you're about to go on to about the male causes then?
But I think one of the most common ways that people would sort of split them up is pre-testicular causes, testicular causes, and post-testicular causes. So if you think of the pre-testicular causes, so these are typically problems that reside, say, in the pituitary gland or in the hypothalamus, or problems that cause problems in the pituitary hypothalamus. So obviously there are a few different hormones that are produced by these structures, say gonadotropin-releasing hormone or FSH or LH, and the purpose of these particular hormones is to instruct the testicles to produce both testosterone and also involved in sperm production. So thereby anything that affects production of or release of these hormones is going to affect sperm production. So these are not particularly common, but things like Kallmann syndrome, for instance, where someone is born without the capacity to make GnRH, is a pretesticular cause, or Prader-Willi syndrome is another one, or if there is a benign or malignant lesion in either pituitary or the hypothalamus, that can cause some of these pretesticular problems. And I guess the testicular problems themselves, so you can get genetic abnormalities that result in impaired actual sperm production itself. So these are often genetic, as I said, genetic causes. So you can get either microdeletions of the Y chromosome in particular regions that code for sperm production, so what we would call Y chromosome microdeletions. These can result in abnormal or absent sperm production altogether, and as well as an abnormal number of chromosomes altogether, such as Klinefelter syndrome. That can cause absence of sperm production as well. And then you can get sort of other iatrogenic causes, such as radiotherapy. The testicular tissue is extremely sensitive to radiotherapy, and if the testicles are exposed to a certain amount of radiation, then again, sperm production itself will be, or testicular tissue, and therefore sperm production itself will be affected. And then, as I said, finally, the sort of post-testicular causes. So these are causes whereby you could think of the pipes or the actual structures that are affected such that sperm production is being made. So the pituitary is actually sending the right hormones to the testicle. The testicles are able to make the sperm, but the sperm are not actually able to be released, so to speak. And therefore, if they can't actually meet an egg, and therefore, obviously, an embryo won't be able to be created. So I guess the most common cause of this is a vasectomy. Infections can also cause sort of some blocked ducts and other sort of causes that you may be born with, so bilateral absence of the vas deferens. Interestingly, this can be a sign of someone being affected with a variant of cystic fibrosis. So that's often, if you examine someone, or let me go back a step, if you do a semen analysis for someone, they don't have any sperm, you examine them, you can't feel any vas deferens there, then you would certainly should be testing them for cystic fibrosis. So that's something else that can be a post-testicular cause. So again, just splitting them up into that pre-testicular causes, testicular causes, post-testicular causes, good way of sort of conceptualizing it. And once you understand that sort of how sperm is actually produced and released, etc., it's actually quite simple to remember.
And for the combined causes, both the male and female combined, are there any particular causes that can cause infertility that way? I always wonder whether, given that there is a joining of two different genetic materials, where there could also be an immune response that could affect infertility. Has that ever been shown to be an issue?
Yeah, look, it's probably a controversial area. I'll often have people ask me, is there like an incompatibility problem? Are we just not compatible? To my knowledge, there's no real such thing as that. I guess when we talk about combined sort of factors, what we're really referring to is the fact that there is an issue with the woman and an issue with the man. Not so much that there's an issue with this specific woman trying to achieve pregnancy with this specific male. It's more the fact that the woman has endometriosis and the fella has sort of poor quality sperm, and they're sort of independent factors of each other, but they've both got a problem. But again, it's very surprising that how many people don't realize that, male factor in particular is a very common cause of infertility. I think a lot of people come to a clinic, and certainly a lot of women, almost expecting themselves to be the problem, or for them to have the problem. And again, it's actually not the case. So sometimes you really got to convince them, look, we need to do a semen analysis here, because there's every chance that's where the problem resides.
What about other causes such as smoking and general health?
Yeah.
What role does that have to play in, and I believe alcohol too may have a factor to play in fertility?
Yeah, I mean, smoking is a big one. There's no two ways about that. Very, very harmful. And so certainly smoking can affect egg quality. It can affect sperm quality. So things like smoking and other drugs or other various toxins, they can increase the amount of oxidative stress within sort of sperm or eggs, and this increases the amount of sort of free radicals, and it can damage the DNA fragmentation, particularly within sperm. Look, the good thing about, I guess, sperm is that the whole life cycle of sperm creation, it's a continual process, right? And so it takes about, let's call it 70, 72 days. And so the good news is that if you've got a smoker, they come in, they do a semen analysis, their parameters are suboptimal, you can quite confidently tell them, like, quit smoking, let's improve our lifestyle factors, let's repeat the semen analysis in, say, 3 months, and there's every chance it's going to be improved. Now, I'm not necessarily saying it's going to be perfect overnight, for instance, but it can actually be improved. Whereas, I guess women certainly, again, you'd still suggest that they do stop smoking and other sort of environmental factors. But again, there's not that constant production, so to speak, of new eggs. Women are born with every egg they're ever going to have. Whereas, again, males, that constant sort of production of sperm throughout their life, really. So certainly lifestyle factors are a big one. Weight, obesity, absolutely, it's a big factor. Smoking, you've mentioned. Alcohol, certainly if you're having a six-pack every night, that's not going to be helpful. But my general sort of view is the odd glass of wine here or there, or the odd sort of beer when you're out is not a major issue. I don't think people necessarily have to live the absolute perfect lifestyle, the perfect sort of life in order to achieve pregnancy.
And when we look at a couple presenting, I presume you start off with a baseline assessment and we'll look at the general health of the patient and talk about those factors we've just talked about just now. But then when you go to investigate them, generally you'd start with types of blood tests to assess their levels of hormone levels. I believe the Müllerian hormone is one, which is a new test available nowadays, and there are other tests you might assess, such as testosterone levels and things, are there in the male?
Yeah, absolutely. I guess generally, like if you've got medical students listening to this podcast, like as with any sort of presenting person or presenting couple, you take a history and you do an examination, right? So you ask them about their presenting problem. You'll talk about their past medical history, what medications they're on, etc. If we're sort of taking a history from a woman, you'd want to know about their menstrual cycle, the regularity. Is there any pain associated with it, which again may be a sign of endometriosis. But certainly once you get past doing all the appropriate history taking, as you rightly pointed out, you then move on to getting some tests done. So I guess in terms of the male, starting off with the male, look, unfortunately, the reality is that the only test we've still got to assess male fertility is a semen analysis. And look, truth be told, that's a very crude measure of fertility. The parameters were actually taken from very fertile men. So again, I'll often have someone that's come in and their motility is a little bit low. So let's just say, for instance, you want to see more than 32% of progressive motile sperm. Sometimes they might come in and it's 29%. Now, again, that doesn't mean they're infertile. There's every chance that there's a whole bunch of guys out there with a similar sort of sperm motility number that are achieving pregnancy on their own without any trouble, right? And so you've got to kind of put a whole picture together. And the semen analysis, as I said, it's important. And certainly if the motility was 2% or the morphology, which you want it to be more than 4%, if that was 1%, or if the sperm count was drastically reduced, then certainly you need to talk about that and perhaps do some additional tests based off that. But the initial test is typically just a semen analysis. If the semen analysis came back showing a very poor count, for instance, that would sort of then trigger a cascade of additional tests to try and work out why it is the way it is. And you can almost imagine what those tests might look like going back to what those pre-testicular, testicular and post-testicular causes are, right? So you'd do a bunch of reproductive hormones. So you would look at their FSH levels, their LH levels. You'd look at their testosterone levels. You would do a genetic screen to make sure they had the right number of chromosomes. You would look for Y chromosome microdeletions. Perhaps you would do a testicular ultrasound to make sure that there wasn't any sort of lesions there or a varicocele there, which can affect sperm quality as well. So I think once you've sort of got an idea in your head about what the causes are, it's very easy to then remember what sort of tests you do. But again, coming back to the male, the main test is initially that semen analysis. I guess moving on to the woman, similarly, you'll do a series of blood tests, which would look at their reproductive hormones. You want to look at their thyroid function. You also want to do in terms of the blood test, you already mentioned the AMH test, which stands for anti-Müllerian hormone. So you're right, this is a relatively, it's been around for a while now, but this is a test that gives us a good idea about what a woman's ovarian reserve is like. So as I mentioned earlier, a woman is born with every egg they're ever going to have. And so the traditional way of testing a woman's ovarian reserve was to do an internal or transvaginal ultrasound at the right time in her cycle. And you would see a certain number of antral follicles, and from that you would gauge whether they've got a good egg number or a good egg reserve or a high egg reserve or a very low egg reserve. Thankfully, a blood test is now able to quite accurately basically also give us the same information. And so basically in a woman's ovaries there's a pool of dormant immature eggs, or what we would call primordial follicles. And this pool of primordial follicles release the hormone anti-Müllerian hormone. And so by testing that particular hormone, we get an idea of, is this pool of eggs high, low, normal. And so that can be quite useful information. So that would be part of the blood test that we would do. We would then also do a pelvic ultrasound, looking for some of those anatomical factors that I sort of outlined earlier, looking for fibroids, looking for polyps. You would do a flushing of the tubes to make sure that the tubes were open. And that would be the main test. You may do a test of ovulation. So if a woman has a regular 28-day cycle, for instance, you might choose to do what's known as a mid-luteal progesterone level. So based off a 28-day cycle, you do it on day 21. And a higher progesterone level would indicate that the woman is ovulating appropriately. So again, they're the sort of the main initial tests that we would do.
Excellent. That's a great summary once again. Very, very structured. Looking at the main treatment options, what are the main treatments that are used nowadays, the most common ones you use in your practice? I'd like to let you know that Aussie Med Ed is supported by HealthShare. HealthShare is a digital health company that provides solutions for patients, GPs and specialists across Australia. Two of HealthShare's core products are Better Consult, a pre-consultation questionnaire that allows GPs to know a patient's agenda before the consult begins, with the aim to reduce admin and free up time during a consult, and HealthShare's Specialist Referral Directory, a specialist and allied health directory integrated into GP practice management software, helping GPs find the right specialist. You can find out more from healthshare.com.au.
I guess doing those initial tests is so important because hopefully you can identify what the actual problem is and target your treatment based off that. So coming back to those common female problems, we talked about ovulatory disorders. So if a woman's cycle is very irregular or perhaps is absent altogether, then you can do what's known as ovulation induction. So this is a very simple treatment that we would offer where we would give the woman some tablets that she would take typically for about 5 days early in the cycle. And the idea of these tablets is to essentially trick the body into making more follicle-stimulating hormone from the pituitary gland, so FSH. And so the body produces more of this hormone, and that hormone stimulates follicles to grow. And during the ovulation induction, we would monitor the ovaries just to make sure that there is only one follicle being produced. You don't want 3 follicles because, as you can imagine, then you're at risk of ovulating 3 eggs, and that can result in things like triplets. So we don't want that. So during the ovulation induction, ideally, we're monitoring the ovaries. When it looks like there's a nice mature-sized follicle there, sometimes the woman might just ovulate on their own, and we would know that based off blood tests that we're doing at the same time. Or we may just give them a trigger injection, which would induce ovulation to occur. We would then ring the woman up and say, look, you're about to ovulate, and they can obviously try on their own at home for pregnancy, but they would get certainty over ovulation timing. So now the goal of this treatment is to help people achieve natural conception on their own, and more specifically, help with regards to ovulation and then obviously intercourse timing. So it can be a very useful treatment where the problem simply resides in the fact that the cycle is quite irregular or absent altogether. So that would be probably the most simplest treatment we would offer. And again, it's really only useful for those where the cycle regularity is an issue. I guess moving on to other treatment options, if there's an anatomical problem such as a uterine polyp or fibroids, or if a woman who describes painful periods goes on to have a diagnostic laparoscopy, which is keyhole surgery, where a camera is placed through the belly button to have a look inside the pelvis. Sometimes you can see endometriosis there. And provided that the disease is relatively mild, the evidence shows that removing that endometriosis surgically can improve the chances of natural conception in the subsequent 6 months. Now, not drastically so, but it can improve things. So that's another treatment option that may be relevant for some people. And again, surgery for other anatomical problems such as removal of polyps or removal of specific types of fibroids. And I want to stress that point because fibroids are very common, but not all types of fibroids can affect fertility. It's mainly the fibroids known as submucosal fibroids, and these are fibroids that grow into the cavity. Yeah, so they would often, or you'd recommend removing those if they were found on ultrasound. Yeah, so surgery is another sort of treatment option where it's relevant. And then I guess we're also then talking about artificial insemination. Now, this is a treatment where you would offer couples if the sperm parameters were a little bit borderline, if the count was a little bit low, if the motility was a little bit low. What you would do for this treatment is you would track a woman's cycle. You would assess when ovulation was about to occur based off blood tests. And then the fellow would come in, he would produce a semen sample for us, and in the lab, they would prepare that sample so just the best swimmers are left behind. And you would have a pellet of the guy's best quality sperm, and the woman would come in and we would very carefully pass this or inject this sperm into the uterus. And as you can imagine, if you've only got the best quality sperm left behind and you're passing it through the cervix into the uterus, i.e. closer to the egg, there is going to be an improved chance of pregnancy with that option. So that's not a bad option in the sort of the right circumstance. And I would deem that to be, as I said, sort of borderline or slightly worse sperm parameters. But for lots of people, the main treatment option would be proceeding with IVF.
Well, that sounds excellent. The window of opportunity when sperm are around the cervix obviously will vary depending on anatomical variations in the female and also the sperm quality. But in general, for the average person, say someone who isn't having infertility issues, what's the window of opportunity for conception?
If we're talking about the fertile window, let's go off a 28-day cycle, right, which is sort of a regular cycle for lots of women. Based off that, you would expect ovulation to occur around day 14. So ovulation being when the egg is actually released from the ovary, right? Now, the egg itself or the oocyte itself can last for about 24 to 36 hours before it essentially dies off, okay? Unless, of course, it's fertilized. But sperm in the body will last for 5, perhaps even up to 7 days in the body before it, I guess, dies off. So what you want, and look, again, I'll see sort of women all the time that are, doing a lot of ovulation kits or tracking, and there's this notion where you need to know the minute that you're ovulating. And the truth is, if there's lots of sperm sitting there in the fallopian tube waiting for the egg to be released, you don't need to time things perfectly. But again, broadly speaking, on a 28-day cycle, if ovulation is occurring about day 14, I would say intercourse every second day from day 9 to 15 is sufficient. Now, obviously, that may vary based off a woman's cycle, and some people have a shorter cycle, some people have a longer cycle. But again, there's a pretty wide window there. So I think a lot of couples understandably become very sort of anxious or get very focused on exactly what day am I ovulating. But if a woman's very lucky and has a very regular cycle, then you don't need to put that much sort of pressure on yourself or monitor things that closely, so to speak.
And obviously that would vary depending on all the factors we talked about. So poor quality sperm wouldn't last as long, I suspect.
Oh, absolutely. Yeah, so it's probably not so much that it doesn't last as long, but it's actually quite an extraordinary journey when you if you look at things in scale of the journey that the sperm has to get through when it's obviously in an ejaculate, it's obviously deposited in the vagina, and that's a particularly sort of acidic environment. So semen itself is supposed to counteract that sort of acidic environment of the vagina. A woman may notice mid-cycle that they get a bit of mucus around the cervix itself, and that's sort of nature's way of making sure that only the best quality sperm get through the cervix into the uterus. So there's a big barrier there as well. And once in the uterus, again, it's a huge journey to get from just certainly the vagina through the cervix into the uterus, and then from the uterus all the way up where there are sort of other pathogens that attack the sperm as well. And perhaps if 200 to 400 million sperm are sort of deposited in the vagina, there's probably only perhaps only 100,000 that actually get to the vicinity of the actual oocyte, which is in the fallopian tube. And so it's actually, the sperm has to, as I said, travel all the way up the uterus and then go into the fallopian tube, and that's where the egg is hopefully waiting, and obviously only one sperm will actually hopefully achieve fertilization. The amazing thing is and again, coming back to what makes fertility as a discipline so interesting is that you get to see all this happening under a microscope in the context of IVF. Like you actually see an egg fertilized and an embryo growing under a microscope. It's quite extraordinary, and you're putting this tiny little embryo, you can't even see it with a naked eye, of course, into a uterus, and I guess when things go well, it's extraordinary what that turns into 9 months later.
I think the terminology's changed from when I was growing up to be whether it was called the test tube babies to is now called what is intracytoplasmic sperm injection. Is that the correct terminology for it? Or?
Oh, look, so ICSI is what you're sort of describing. That's a fertilization technique. So for instance, there's 2 different types of fertilization techniques. So again, perhaps I'll go through what IVF is and we'll get to what ICSI is. It's kind of part of that. But the IVF itself, I talked about in a normal menstrual cycle, a woman produces one dominant follicle and ovulates one egg. Whereas in IVF, what we want to do is we want to help the woman grow as many eggs as they safely can within their ovaries. and we want to then collect the eggs. We don't want them to release the eggs. So the process starts with a woman's period, and then they then take the hormone, I've already mentioned it before, follicle-stimulating hormone. This is an injection. We give it to them in a very high dose. So it's a high dose of follicle-stimulating hormone that they would start with, well, specifically day 2 of their cycle, and typically take it for about 14 days. During that time, you will be monitoring the ovaries with blood tests and scans because we want to make sure that these follicles, hopefully, lots of them are growing. And we would aim for somewhere between 8 to 15 of these nice follicles growing. When it looks like, based off a scan, that the follicles have reached a mature size, they would come into our unit and in theatre. It's a pretty quick and pretty simple procedure. It's a 6 or 7 minute procedure where you put a thin needle under ultrasound guidance through the back wall of the vagina, into the ovary, into each of these mature follicles. And in each follicle, there will be fluid. And you aspirate the fluid from each of these follicles, and hopefully, in most of them, there will be an egg. Now, on the same day, the woman's partner will produce a sperm sample at our andrology lab. And again, that sperm sample is prepared, and then it will come time to actually fertilizing the eggs that we've collected. And this comes back to what you've just mentioned, which is intracytoplasmic sperm injection. So in some circumstances, we might need to, under high magnification, specifically pick out one sperm and inject that sperm into that egg to try and achieve fertilization. Now, the most common sort of indication for that would be if the sperm or if the semen analysis done prior was very poor. Now, if the semen analysis, on the other hand, was really good, you can do what's known as standard insemination, which is instead of picking one sperm out and injecting it into the egg, you can literally put a little bit of semen around each egg in essentially a petri dish, and you come back the next day and hopefully one of them is fertilized. And so they're the 2 different fertilization techniques, either standard insemination or ICSI. Now, on average, you might expect perhaps 60% of the eggs that we collect to actually fertilize. We don't expect them all to. And of those, perhaps half will develop over the course of about 5 days into good quality embryos that we would call blastocysts. And then about 5 days after the egg collection, you will take one of those blastocysts and very carefully place it inside the uterus. That's like having a pap smear done. It's pretty straightforward. If we've got more than one embryo, which most of the time we do, you would freeze the other embryos, and then 2 weeks later we would do a pregnancy test. And fingers crossed it's positive. And if it's not, and we have to do the whole thing again, well, again, fingers crossed if we've got embryos in storage, we don't have to go and repeat the whole IVF cycle again. We can literally take the next embryo out of the freezer and transfer it into the uterus at the right time. So it has to be timed appropriately. It's not at any point, but that's called a frozen embryo transfer. And that's IVF.
What temperature are the embryos stored at?
That's a good question. So they're vitrified these days. So it's a fast sort of freezing technique. I couldn't tell you the exact temperature off the top of my head. I'm sorry. Look, it's pretty low. So they used to do a different sort of freezing technique called a slow freeze. The problem with that is that it created sort of these ice sort of crystals on the embryo, which turned out to be quite toxic to an embryo. So then they developed this new sort of freezing technique called vitrification, which is essentially you're plunging embryos into liquid sort of nitrogen and they just basically freeze instantly. And that was found to be much, much safer. It's quite extraordinary how many people on Earth now exist that, had they been born in another era, simply wouldn't exist.
Truly amazing when you think about it. Where do you think it's going to take us in the future? What are the next steps?
Look, it's a difficult one, I guess. Like it is a relatively rapid moving field, which I guess I find quite appealing. I think probably the last 10 years we've done sort of amazing work in terms of trying to find which embryo to transfer. And so certainly we've done some amazing work in the field of genetics and genetic testing of embryos. You can now, with a reasonable amount of accuracy, actually test embryos, not just to make sure they've got the right number of chromosomes, but you can actually test for very specific condition like cystic fibrosis, for instance. So again, we've done a lot of great work in terms of genetic testing of embryos and working out which embryos to transfer, etc. I think the field at the moment, we're still at a little bit of a loss. Sometimes some women, they make beautiful embryos, but the embryos just don't implant. And so even if we transfer, as I said, a euploid or genetically normal embryo at the right time, there are no other factors that we can identify as being a problem. Pregnancy rates at best are around 60%. That's relatively kind of inefficient if you think about it. It's relatively low, really. Why isn't it 95%? The answer is we don't know. So I think there's a lot more perhaps work and research that needs to be done in the field of sort of implantation, and why is it that some women have implantation failure. And I guess other sort of areas, and I think this is probably going to be relevant for lots of areas of medicine, not just mine, which is sort of the field of artificial intelligence and machine learning. It's quite extraordinary, the stuff that's going on in that discipline. As of probably a year or two ago, I get starting to into the field of reproductive medicine. It used to be that an embryo was like, let's just say a couple go through IVF and they make 4 embryos. The embryologist would then grade those embryos based off how they looked on very specific sort of static points during their growth, and how they obviously their growth and how they look. And they would grade them and then pick which embryo to actually implant. But in recent times, there have been incubators developed with machine learning and AI software that are incorporated in those incubators that are monitoring the growth of these embryos 24 hours a day, essentially, throughout from their creation through to the time of embryo transfer. And there are probably dozens of factors within an embryo's growth that simply the human eye can't pick up or we don't know about, but a computer can. And in fact, one of the world leaders in this technology is a company right here in Adelaide. You could Google it, called Life Whisperer. You may have heard about it. And they've developed an incubator with this sort of software in it. And there's another company called Harrison AI out of Sydney that's also developing it now. If we're wondering where the field is going, I think the use of artificial intelligence to help guide sort of clinical decision-making is going to be a big part of fertility medicine. And as I said, I think every aspect of medicine pretty soon.
Well, that's absolutely fantastic. Look, this has been a great overview. I think you've summarised things beautifully, and I've really appreciated you coming on Aussie Med Ed. So, look, I'd like to thank you again, Vamsee. It's been excellent and brilliant discussion. So thank you very much, Vamsee Thalluri.
You're welcome. Thanks for having me on. Appreciate it.
No worries. Thank you again. Well, thanks once again for listening to our podcast, Aussie Med Ed, or the Australian Medical Education Podcast. We really enjoy hosting this podcast. I hope you find it useful to hear a pragmatic approach to everyday conditions. If you have any questions or information you want to ask about us, or you'd like to put a suggestion for a topic, please don't hesitate to email us at gavin@med-ed.com.au. Once again, I hope you've enjoyed listening to it, and we look forward to hosting it next fortnight when we introduce a new topic. Thank you. Aussie Med Ed is proudly sponsored by HealthShare, a digital health company that provides solutions for patients, GPs and specialists across Australia, and Tego, offering medical indemnity insurance for doctors. That's tego.com.au.